I will explain this later. This is a research review. A typology can be useful in understanding the key framework. Because the typology of healthcare system has been developed and influenced their research organization, regulation, financing, service delivery, service providing, etc. Then, how to make typology to explain certain patterns of healthcare systems. Many scholars have studied to establish typologies of healthcare systems, but among the several typologies discussed, relatively well-known health system types are three. The first one is the national health services model is characterized by universal coverage, funding out of general taxation and public provision of health services. The UK and Sweden belong to this model. Secondly, the social health insurance model is characterized by contributions paid by employees and employers, the public and private provision of health care, as well as the compulsory coverage for the population. Germany and France are the main examples of this type. Finally, the private health insurance model, healthcare is funded by individual and employer premises in health delivery relies predominantly on private ownership. So, as I mentioned, these systems are well-known types of healthcare systems. However, South Korea and Taiwan have moved along different paths compared to many countries. Focus on these 4 countries. Then, what is the performance of healthcare system? Before we analyze the performance of healthcare system depends on their institutional arrangement, we have to define the concept. There are many factors influence on the health status of population. So when we measure the performance of healthcare, we have to take into account financial resources to access goals, demographic, economic, social context, and design of a health system. In addition, our paper is a comparative study regarding relationship between the institutional arrangement and their performance. So we have to find comparable cross-national data for assessing the performance of healthcare systems. In previous studies, health spending, infant mortality, and expected life are used to measure the performance of healthcare systems. Clearly, these variables are necessary to assess the amount of financial resources, total medical technology. However, they are not sufficient to assess the performance of healthcare because these variables are limited to output. So let's consider all of the healthcare systems. These are the goals of WHO and OECD when we provide healthcare services. In WHO case, there are 3 fundamental goals of healthcare system: improving health, enhancing its representatives, responsiveness, and assuring fairness of financial contribution. The OECD has proposed a conceptual framework adopting many aspects of WHO framework. In terms of dimension of performance, there are 3 goals: health improvement and outcomes, responsiveness and access, and financial contribution and health expenditure. Unlike in the WHO framework, OECD stressed the access as a determinant of responsiveness. Here, access is designated as an essential component of responsiveness. So, we measure the performance of the healthcare system, not just only consider the qualitative variable, but focus on the quantitative variable, but also focus on qualitative aspects. These are the analysis tools. Institutional design can affect the performance of healthcare system. This is our hypothesis and hypothesis. At first, let's see the institutional arrangement of a healthcare system. There are many variables to influence, but we are choose financing services regulations are dimension and performance of healthcare system measured by effectiveness, efficiency, accessibility, and responsiveness. As the first to see institutional arrangement of healthcare system, we divided the dimensions financing service regulations based on the previous study. I will explain this by this. Most countries use a mix of public and private financing, but degrees are different. Depends on what is the main source of financing, such as tax, social health insurance, private insurance, etc. And the type of coverage, such as single national or local schemes, multiple insurance, are also influenced because the coverage and cost of healthcare services are influence these factors. In the public integrated model was based on public financing like tax and public provision by government medical facilities in UK. In contrast, in United States, insurance is voluntary and may not be affordable for individuals, and insurers selectively contract with competing. In Germany and Korea, they rely on social health insurance and often supplemented out of general tax finance government. Like this, beyond financial arrangement and coverage entitlement, countries differ in the organization of the supply of basic coverage. Provided payment arrangements are simply one of the most determinant characteristics of health system. So enhancing competitive pressure of providers can have a number of positive impacts, such as increasing productivity, reducing cost of providing, and some countries have a gatekeeping system that limits patient choice among providers. So in this system, patients have to meet a general practitioner referral to access special care. And many countries have adopted volume incentives to providers through salaries or others. In NHS model, government over the private is strong, and in the social health insurance model, the role of the state or the private sector is generally limited to that of a regulator. So we consider the degree of decentralization to sub-national governments and degree of delegation of insurance, regulations of the health workforce and equipment, and prices billed by providers. And next, these are the variables to measure the performance of the healthcare system. Effectiveness, efficiency, accountability, and responsiveness are variables. At first, effectiveness, as I explained, impact mortality, expected life are used to measure the performance. And we added the variable quality of primary care and measure because this like these diseases are delivered by primary care providers and avoidable. So hospital administrators are and in-hospital mortality due to these diseases. So these are proper indicators to measure of the quality of primary care. Mortality rates alone are not sufficient to measure quality of care because current mortality rates reflect the effect of cancer care in past years. So the relative survival rate of cancer is commonly used to track progress in treating a disease over time. And perceived health status, which was provided from OECD, reflects people's overall perception of their health and measured by respondents. Then accessibility. Out-of-pocket payments are expenditure by a patient, whereas insurance does not cover the full cost of the health services and covers over healthcare, physicians, dentists are proper and variable to accessibility. I will have this variable explained because I don't Anyway, these are the research results. And first, health financing. In most OECD countries, the public sector is the main source of health financing. However, U.S. case public share of expenditure on medical services, total health financing is just 47.7%, which is lower than average of OECD countries. There are multiple insurance, and the government has stressed efficiency across competition among these providers. And there is no limitations patients choose to providers. The ratio of public beds of total hospital is 73